Arun sir, should we start?
Arun,
So, Parker sir, can we start the
yeah,
session?
I think we can start. Yeah.
So maybe we can start by setting
Yes.
the
Okay. Okay.
stage.
Very good evening to you all. And today we are having the annual meeting of the Cochin Oncology Group. This is the fifth annual meeting, and today we are very lucky to have three international speakers: Dr. Jame Abraham from Cleveland, Dr. Kurian from Canada, and Dr. Shaheenah Dawood from Dubai. And as you all know, the breast cancer management has changed a lot in the last decade. And during the last 2 years itself, there have been many new introductions to the treatment of breast cancer. And Dr. James is currently professor of medicine and the chair of medical oncology and hematology at Cleveland Clinic, Ohio, USA. And the first talk is by Dr. James. He will be talking on what is new in the anti-HER2 therapy in early breast cancer. Over to Dr. James.
Right. Thank you, Dr. Ferguson. Again, you can see my screen now?
Yes, yes, yes.
Right. Okay, perfect. It's, right. Okay, thank you again. Again, good afternoon or good evening to all my friends in India. It's a privilege or honor for me to talk to you all from this beautiful fall morning in Cleveland. Again, I thank Dr. Pavitran and Cochin Oncology Group for inviting me for this talk. So I'm going to talk about management of HER2 positive early breast cancer. So when I talk about HER2 positive early breast cancer, I think I have to talk about NSABP B-21. Again, senior oncologists like Dr. Pavitran will know the history. So this is the first trial which actually introduced trastuzumab or HER2 targeted agents in early breast cancer. So this patient, she was 33 years old when I saw her in 2001. She was my first patient when I started my oncology practice after fellowship. So she was 33, the stage 3 breast cancer, multiple lymph nodes positive, and a F4 centimeter tumor. And she had ER, PR positive, and HER2 positive tumor. So by immunohistochemistry that time, predominantly we were doing IHC. She enrolled on this clinical trial, and she was randomized to the control arm. And as you know, control arm is adriamycin, Cytoxan, followed by Taxol. And of course, the interventional arm is AC, followed by Taxol plus trastuzumab. So in 2005, after listening to the presentation at ASCO, I'm sure probably Dr. Pavitran and some of your senior oncologists were over that meeting. In 2005, I called this patient, Cynthia Smith. She's so I called her from Chicago and said, Cindy, you're coming back. I'm going to give you trastuzumab. The reason is, as you can see, almost 30% improvement in overall survival and 50% improvement in disease-free survival based upon adjuvant trastuzumab for 1 year. So even after 3 or 4 years, we called our patients and gave trastuzumab because it's a really a study which changed the treatment of one of the most aggressive breast cancer in the past, let's just say, 15 years. So as I said, in 2001, we had no drug in early stage breast cancer. In 2005, based upon the B31 and 9831 of HERA trial, trastuzumab was approved. Now we have trastuzumab, pertuzumab, TDM1, and neratinib. And then, of course, in metastatic setting, we have multiple agents. So this is the overview of my talk. I'm going to talk about neoadjuvant setting, some of the adjuvant regimens, and then some of the clinical trials which are in development. Again, as all of you know really well, breast cancer treatment, especially HER2-positive breast cancer treatment, should be done in a multidisciplinary manner. It should be done with, after discussing with the pathology, radiology, the surgeons, medical oncology, and radiation. So it should be a multidisciplinary approach. This is not a new concept for any of these people on this call. In this meeting, about 20 to 25% of all breast cancers are HER2 positive. We test that either by immunohistochemistry or FISH. It's more common in young patients, and it's associated with poor prognosis and increased chance of metastatic disease and poor disease-free survival. So this is the overview of my, or summary of my talk. So in early breast cancer, let's just say if the patient has a stage 1 disease, especially ER positive, I'll treat that patient with paclitaxel and trastuzumab. In stage 2 and above, especially T2N1, that patient will be considered for neoadjuvant treatment. Let's just say if I happen to see someone with the stage 2 breast cancer, multiple lymph nodes positive, I may pick one of these regimens, TCH, TCHP, or AC followed by THP. In post-neoadjuvant setting, based upon the Catherine trial, if the patient has residual disease, the patient will be randomized to TDM1. No residual disease either, we can treat with single agent trastuzumab or trastuzumab plus pertuzumab. And in extended adjuvant setting, we'll use neratinib. So this is a summary of my slide. So if you are still with me, this is the slide. And if you want to go back and check your WhatsApp, and no, this is it. I'm not going to say anything more than nothing more than this. So I'm going to take you through a few patient story. This is a young patient with fairly large tumor. As you can see, fairly large axillary lymph node. The lymph node was about 5 centimeters or so. And the biopsy showed ER positive, PR positive. And again, in HER2 positive setting, as you know really well, the PR tend to be lower or negative. So it's a young patient with locally advanced breast cancer. In this setting, we will consider neoadjuvant chemo for this patient. Again, the indication for neoadjuvant chemo, as per NCCN, inflammatory breast cancer, bulky or matted lymph nodes, or entry lymph nodes, supraclavicular, or skin involvement. But in patients with HER2 positive and triple negative, in general, we lean more towards doing neoadjuvant chemo, because in post-neoadjuvant setting, we can optimize the treatment based upon the response. So this is one of the 2 trials which actually showed efficacy of pertuzumab in neoadjuvant setting, the NeoSPEAR and Trifina trial. Both showed in ER, PR negative, HER2 positive breast cancer, response rate up to 70%, and ER positive, HER2 positive, complete pathological response up to 50%. So this is based upon this trial, FDA approved pertuzumab in neoadjuvant setting in 2013. So we've been using pertuzumab in neoadjuvant setting since 2013. And in our practice in Cleveland Clinic and NCCN, in general, we follow TCHP, that's docetaxel, 75, carbo, AUC of 6, pertuzumab, and trastuzumab after loading dose given every 3 weeks. In general, I don't use an anthracycline containing regimen. So when I say I, that's Cleveland Clinic, and even in our NCCN group, in general, we don't use an anthracycline commonly in HER2 positive. So why is that? So if you look at the TRAIN2 study, which is presented at ESMO or ASCO, which actually looked at the role of, this is more like a TCHP regimen. So this is paclitaxel, trastuzumab, carboplatin, pertuzumab versus an FEC trastuzumab, pertuzumab regimen. And so the primary endpoint is pathological complete response, and the secondary endpoints are, of course, toxicity. And you can see the complete pathological response is almost 70% for both anthracycline containing regimen and non-anthracycline containing regimen. Again, anthracycline containing regimen, non-anthracycline containing regimen. So there was no difference with a p-value of 0.75%. And the event-free survival was again similar. So, so in a locally advanced breast cancer, stage 2 and above, if I'm giving neoadjuvant treatment, in general, I pick a non-anthracycline containing regimen. So we use docetaxel, carbo, trastuzumab, and pertuzumab. Probably in a handful of settings. I don't know when was the last time I used an anthracycline containing regimen, but we can always use AC followed by THP. So let's just say after the completion of neoadjuvant treatment, if the patient has a complete response, then we can continue with trastuzumab or trastuzumab plus pertuzumab. And if the patient has residual disease, we'll switch to TDM1 or either trastuzumab emtansine. So this is kind of the schema. So a HER2 positive, ER positive, after neoadjuvant chemo, if they have complete response, trastuzumab plus or minus pertuzumab. And especially in ER positive, I will recommend using neratinib. And again, I'll talk about XNET in a second. So, and then there is always debate about the role of pertuzumab in this setting because many of these trials were not done with pertuzumab. But if I'm selecting a patient for neoadjuvant treatment, I know that patient is high risk, and then those patients I'll use pertuzumab. Again, in NCCN, we actually put pertuzumab after an asterisk. So let's just say if residual invasive cancer, then based upon Catherine, we'll switch to trastuzumab. And then in this setting, role of neratinib is probably limited to none. And in NCCN, again, we put that under like a bullet point. So again, switching to TDM1 is based upon the Catherine trial, NSABP B-50 or GDG. Patients with residual invasive cancer were randomized between trastuzumab versus TDM1, given every 3 weeks for 14 doses. And it's, again, I know I'm talking to a scenario where TDM1 is extremely expensive, but I'm just saying the practice what we have here. So it's important for us to review the eligibility criteria for B50. Any patient with a T1 to 4, N0 to 3. So, but T1A, T1B were not eligible for this trial. So those patients received neoadjuvant chemo. Then if they have any residual invasive cancer, that's key, in breast or axillary. So I get calls from, for second opinion, if the patient has a DCIS, what should I do? Or microinvasion, what should I do? So in those patients, you don't need to switch. So all patients benefited by switching to TDM1. And on about 20% of patients had pertuzumab in neoadjuvant setting, and most of those patients were actually from North America. So, and as you can see, an improvement in invasive disease-free survival, and almost 30% improvement in invasive disease survival based upon this, the FDA approved this drug. Of course, it was published in New England Journal. So in post-neoadjuvant setting, if they have residual disease, TDM1, no residual disease, keep the same drug. So moving on to some of the adjuvant regimens. So the last presidential debate was right here in Cleveland Clinic campus. You can see that. So let's just say if the patient has a smaller tumor, a 61-year-old patient with a small tumor, 2.1 centimeter, grade 2, ERP positive. In those patients, I'll use weekly paclitaxel and trastuzumab based upon the Serotolini's paper. So if you look at this study, almost 60% of the patients were under the age of 60, and 40% of the tumors were between 1 and 2. So if I'm seeing a patient who is a 1.5 centimeter tumor, she's 50 years old, she has ERPR positive, I have no problem in treating that patient with weekly paclitaxel and trastuzumab. And then we have fairly long follow-up with almost 93 to 98% event-free survival. So let's just say if I happen to see a high-risk patient, young patient, fairly large tumor, multiple lymph nodes, ERPR negative. So in general, these patients don't come to us anymore because all these patients will receive neoadjuvant chemo. I haven't seen a patient like this for the last, let's just say 2 years or so. So let's just say if I happen to see a patient like this, then that's the patient we will add adjuvant pertuzumab in that setting. That's again based upon the affinity trial. This trial randomized about nearly 5,000 patients with or without pertuzumab. And you can see the benefit is not much in node negative or ER positive, but in node positive patients, there was an absolute difference, about 3% or so. Again, the benefit is marginal, but FDA approved pertuzumab in adjuvant setting. So in summary, in adjuvant setting, if I have a high-risk patient, I will consider adding pertuzumab in that setting. If it's ER positive, we'll do extended adjuvant neratinib based upon this XNET trial. This is neratinib, 240 milligram daily versus placebo in patients who completed 1 year of HER2-targeted treatment. Again, those patients are predominantly treated only with trastuzumab, not with pertuzumab or T-DM1. So this data is relevant only for patients who had trastuzumab. And the difference was about 3%. And of course, neratinib is a tough drug to give with diarrhea as a common side effect. So we talked about TCHP in neoadjuvant setting, and adjuvant setting, weekly paclitaxel has trastuzumab, and then or TCH or TCHP in high-risk patients. So my last few slides, I'm going to talk about trastuzumab deruxtecan. If you look at the antibody drugs in development in HER2-positive breast cancer, this is probably the most active drug being developed. So this is, the payload is a topoisomerase 1 inhibitor. It's highly active. And as you know, the Destiny's Breast-01 showed a response rate of 60% in heavily pretreated patients, and then clinical benefit ratio of more than 90%. So FDA approved this drug based in HER2-positive metastatic breast cancer, those who had prior anti-HER2 regimen. So this is commonly used. And then, of course, as you know, the major side effect is ILD. It's up to 16%, especially in Asian or Japanese patients. It's about 10 to 15% in Caucasian patients over here. So now we are designing a study. This is NSABP B-60 or Destiny Breast-05. This will be a global study in patients who have neoadjuvant chemo, especially high-risk patients. And then if they can be randomized between a trastuzumab deruxtecan versus the control arm, trastuzumab deruxtecan versus the control arm, T-DM1 only. The primary endpoint is invasive disease-free survival, and secondary endpoint is disease-free survival. So this, as I said, it will be a global study of about 1,600 patients or so, and 400 sites and 33 countries. And I'll be leading the study in North America for NSABP. Tucatinib is another drug, which is probably one of the most active small molecule or TKI. Now, multiple phase 2 studies, phase 1 and phase 2 studies showed it's highly active, and it's even combined with tucatinib and T-DM1. And this is the registration trial. This is HER2CLIMB, which is heavily pretreated patients, randomized between tucatinib plus trastuzumab plus capecitabine. Again, tucatinib It's 300 milligram POBID, trastuzumab, the standard dose, capecitabine 1000 milligram. So almost 46% reduction in progression or death. So it's a really active drug, and if you look at the efficacy, the CNS penetration is really impressive. So if I have a patient with brain mets now, those who are exposed to a HER2 agent like trastuzumab and pertuzumab, this will be my first choice. So this regimen will be my first choice. That will be tucatinib, trastuzumab, and capecitabine. So based upon the data, Dr. Murthy presented at San Antonio and published in New England Journal, FDA approved tucatinib in metastatic breast cancer. So now the same tucatinib is moving into adjuvant setting. So this is the Alliance trial in patients who have received neoadjuvant chemo. If they have a complete pathological response, they will get trastuzumab and pertuzumab. If they don't have a PCR, then they will be randomized between TDM1 versus TDM1 plus tucatinib. So this is moving into clinic soon. This will compete with the DESTINY-05 trial, but DESTINY-05 is a global trial. So in summary, in a stage 1 patient, we will treat them with the paclitaxel and trastuzumab. Stage 2 and above, neoadjuvant chemo, TCHP in some patients, rarely THP. Adjuvant setting, we will use TCH or TCHP. And again, high-risk patients, potentially we can use AC followed by THP. Post-neoadjuvant setting, we'll use TDM1. If they have a complete response, then trastuzumab. In extended setting, neratinib. And again, we talked about these 2 clinical trials. Again, thank you so much for your time. And I'm really proud to say that I'm a proud graduate of Calicut Medical College. I know there are a lot of Calicut Medical College graduates there. And I have an amazing team over here. This is Dr. Grobmeyer, who was here. He recently moved to Abu Dhabi to lead the cancer program in Abu Dhabi. I'll be happy to take any questions.
Thank you, Dr. Jame, for the very interesting talk. And one of the questions in the chat box was the duration, what is the minimum duration of trastuzumab? Because as far as we are concerned, cost is one of the main issues.
Right, yeah, good question. So I know the trials which showed non-inferiority for 6 months versus 1 year. So let's just say saying from your, if I can say, environment and where you practice, let's just say you have a low-risk patient, it's not unreasonable to stop the treatment after 6 months. But that's not the standard in the West. We still continue to use 1 year of trastuzumab. So the standard is 1 year, but we have enough data to say that 6 months is not inferior. And good to see you, Parvish. Thank you for joining.
Pavitran sir, the next question is also there.
Second question is, if a node positive high-risk patient can't afford dual blockade, should we
quit anthracycline?
Yeah.
Sure. So, so that's a good question. And in HER2 positive setting, especially with those with topoisomerase activity, anthracycline is highly active. It's as active as sometimes like a HER2 targeted agent. So if the patient can't afford dual blockade, that's probably one situation where we should continue to use anthracycline. So that's a good question. Recently, I saw a patient who is 28 weeks pregnant, and then she has, she's in her second trimester of pregnancy. For that patient, she's HER2 positive, second trimester pregnancy, HER2 positive. For her, I started her on AC, and then I'll bring the HER2 targeted agent after. So there are some situations, you're right, anthracyclines we should continue to use, and especially if dual blockade is not available. And I see that in USA, some patients who exhaust their medical insurance and hit the donor effect. So good question, Parvish. So in most of the IV treatments are still covered. So when we give the treatment, when the patient comes here and give the treatment from an infusion center, insurance are covered. The donut hole that apply for prescription coverage usually, not for infusion. And you're absolutely right. I'm saying this from a cost, if I can say, insensitive environment. And here, one cycle of TCHP will cost almost 20,000 US dollar in one sitting. And we are talking about 6 cycles. So that's $180,000 or $120,000 of treatment. All right. So then Ashok, the tumor about 2 centimeter, that's T2 and 0, would be offered neoadjuvant if HER2 positive. That's PCR. All right. Okay. So good question. So, so let's just say if I'm seeing somebody who's 45 and who has a 2.2 centimeter tumor and ER/PR negative, I may consider neoadjuvant chemo. So if you remember the case I put, she's 2.1 centimeter tumor, 61 ER/PR positive. For her, I think it'll be perfect for her to go for surgery and then do adjuvant treatment. So we need to look at the biology, and if the patient meets the criteria for the paclitaxel trastuzumab study, if the patient meets the criteria for that study, then I'll tell the surgeon, go and I take the patient for surgery. I'll see the patient after surgery, so I can de-escalate the treatment. So de-escalation is really important, or optimizing the treatment based upon the biology is so important. Sometimes we just treat everybody the same way. We need to really look at that. A good question. Dr. Dinesh.
So getting a PCR doesn't make a difference, right?
So PCR, so why PCR, why neoadjuvant chemotherapy is more important now? Because if the patient has a residual disease, we can, here at least, again, I'm saying that we can switch the treatment to TDM1. So then we are kind of selecting patients who are resistant to this regimen and changing to that. That's why PCR is important. If the patient has a complete response, then, so if he has ER/PR negative, you can expect 60 to 70% the patient will have a complete response. So that's the scenario.
I have one more question.
Sure.
I put it up that hormone positive, HER2 positive tumor, you complete 1 year of neratinib. How long would you continue the hormonal therapy? For example, the post-menopause patient on letrozole, how long, how much longer would you continue that?
Sure. Hormone treatment will continue to use the same criteria. So the standard recommendation is 5 years. And let's just say if I have a high-risk patient, again, that's based upon NSABP B-22. If I have a high-risk patient, multiple lymph nodes positive, the patient is doing well, I may extend beyond 5 years to 10 years. So that's based upon the B-42. And the HER2 targeted agents won't influence what we, how we, the duration of endocrine treatment. And Dr. Dinesh, can we assess response with a neoadjuvant chemo with imaging and avoid surgery in cases? So that's a really good question. So there were 2 studies completed. I mean, 1 study completed and 1 actually abandoned in the middle. So the first study was from MD Anderson, which actually used neoadjuvant chemo. So as we talked before, almost 60 to 70% of the patients can have a complete response. So the MD Anderson study was give neoadjuvant chemo, then do a breast MRI and do multiple biopsies and see who can, and whom we can predict for sure can have a complete response. So that study didn't show that the biopsy or the MRI clearly correlates with the complete pathological response at the time of surgery. So then NSABP, we were doing a similar trial. And then to see if we have enough, let's just say MRI criteria or biopsy at the time of surgery can predict who will have a complete pathological response. So based upon, since the MD Anderson study failed, we actually closed the neoadjuvant, this particular question in the NSABP. So the key question is we don't have a perfect tool to say who has complete pathological response. That's a good question, and people are wondering that. And a lot of surgeons are nervous about that. So here, Dr. Durga, how often do our patients get pertuzumab? Oh, so that's a question for Dr. Pavitran, I think. Not for...
No, very low, maybe once a year only, like that much only.
Right, yeah. Good question. Anyway, it's a different, again, I'm sorry I'm talking from a different perspective. Dr. Chopra, good to see you. So HER2 affordability is a huge issue. You're absolutely right. No, it's absolutely right. And again, cost of cancer treatment is, again, I'm talking from a cost neutral perspective, and I apologize for that. And I'm not being insensitive. You're absolutely right. Cost of care is like a huge issue. TDM1 infusion is about $10,000 here. So Dr. Bina, early stage T1N1 receiving neoadjuvant PCR post-surgery, post-MRM, what would be the way? So that's a radiation question. I think Dr. Kurian should, and I will answer that question. If I can just move on to the next question. In the neoadjuvant setting, less than 5 year, I don't know if I can see the full question. Can I see the full question? In the neoadjuvant setting, less than a 5 year.
I think it was an answer to what Dr. Durga asked.
Oh, got it. Okay. Thank you for the great questions, though. These are all really good questions.
Thank you so much, sir. Can I request our organizers to, can I hand it over to Dr. Pavitran to introduce our next speaker? Thank you so much.
Thank you so much. Yeah, thank you.
Thank you so much, Dr. Jame. Next talk is by Dr. Kurian on the optimizing adjuvant radiation therapy in breast cancer, challenges and opportunities. Dr. Kurian is Associate Professor and Radiation Oncologist at Cross Cancer Institute, University of Alberta, Canada. Over to Dr. Kurian, please.
So, thank you very much, Cochin Oncology Group, for the invitation, and also Professor Pavitran, thank you very much for the invitation. This is my second oncology group meeting I am attending. I think the first meeting when you formed, I was also there. Anyway, thank you very much. So before start, we have now snow arrived, and this is our downtown like 2 weeks ago, and this is like a couple of days ago. Anyway, so Dr. Pavitran asked me to discuss few controversial topics. So I think there is no controversial topics, only we need a multidisciplinary discussion. And also regarding these cases, the radiation oncologist has to decide or justify the rationale for offering radiation. So regarding our center, we have a departmental and provincial guidelines, and all the radiation cases, new patients are discussed in our multidisciplinary rounds, and that's how we make a decision. And also, it is a publicly funded center by the government, so there is no conflict of interest as well. Now, I'm going to discuss a few case scenarios and then what is the rationale for deciding. So this is the one case we have in May, 63-year-old patient with a left-sided breast cancer patient. She was high risk. She underwent breast conservation surgery and axial lymph node dissection. Then she completed TCH chemo, and then she also had a genetic testing showed ATM gene mutation positive. So the question came, of course, whether she need radiation, and because of the ATM mutation, if you go for mastectomy, whether radiation oncologist still would offer radiation. So there are reports increased late subcutaneous toxicity after RT, And so that's the concern. So before going to the decision making, I just want you to go through few literature. One is from Germany. It's about 1,100 breast cancer patients received RT. They screened for ATM gene mutation, and they found 11 patients, of which 10 patients had ATM gene mutation. And all these 10 patients received RT, and they, at the median follow-up of 5 years, there was no evidence of increased RT-induced acute or late toxicity. This is another presentation in ASCO from Memorial. They reviewed 167 ATM mutation carriers, and they found that 91 received RT, and 65 had breast conservation and adjuvant RT, whereas 26 had mastectomy. And the median target dose was 50 gray. Some received boost radiation. And end of the day, no evidence of excess breast RT among ATM mutant gene carriers. And so the recommendation or the presentation was adjuvant RT can be safely considered in this population. So we had discussion and we decided no co-evidence of contraindication at the current situation. So we offered RT for this patient. Now, regarding radiation, in the olden times, we used to do field conformed radiation, and also the teaching was we should have adequate dose to the skin. But that is an old concept. Nowadays, we use field-in-field MRT, and also or 3D conformed radiation will give lower skin dose because we are using high energy radiation as well. One other thing, if a situation comes is you should not offer hypofractionation. That is the common practice at the moment. It can cause toxicity. So typically we use standard fractionation 50 gray in 25 fractions. Moving to the case number 2, this is a 55-year-old patient with a T2N1 breast cancer and had modified radical mastectomy, FAC chemo, and this patient was referred for adjuvant radiation treatment. So the question comes, is any absolute benefit from RT? So in Canada, now almost all patients go for sentinel lymph node biopsy. So there is the question of axillary dissection comes only even a patient have new adjuvant chemotherapy, and also we do sentinel lymph node biopsy if there is a concern. Otherwise, most of the patient have no issue of axillary dissection. Whereas in India, you know, lots of patients still go for axillary dissection. So we can just review the literature. You know, the old Danish data, I showed actually irrespective of nodes 1 to 3 versus 4, there was a significant benefit in terms of local control. As well as survival. In survival, there was no difference in survival between this study, and absolute benefit was 10%. Then the Oxford meta-analysis showed, this is the node, 4 or more node group. You can see the local regional recurrence was 19% benefit, and then breast cancer mortality was almost 10%. If you look at the 1 to 3 nodal group, still the benefit, local regional recurrence benefit and breast cancer mortality benefit was there. Now, there are 2 recent studies. One is the MA20. They specifically looked patients would benefit from adjuvant RT if they are node positive or high risk node negative patients with systemic treatment. And the eligibility was node positive, node negative with the T3, more than 2 centimeter tumor with less than 10 axillary nodes. And all these patients, 85% of this group was 1 to 3 nodes. The study showed overall survival, there was no statistically significant benefit. However, ER negative patients showed there is a survival advantage. And also all the patients showed disease-free survival. There was a significant benefit of patient received regional nodal radiation. So the conclusion of the study was effects were greater with ER/PR negative tumors, no difference in breast cancer specific mortality. However, additional radiation in regional nodal radiation significantly improved the disease-free survival. And absolute improvement was 5% at 10 years for disease-free survival. And the Oxford meta-analysis showed every 1.5 recurrence prevented by RT at 10 years will be equal to 1 breast cancer death prevented at 20 years. Now, moving to the other study, at the same time published from the URTC group, they also included patients with the stage 1 to 1-3, and these patients, 26% of patients were modified radical mastectomy and 76% was breast conservation. About 50% of patients 1 to 3 nodes. They also reviewed the effect of regional nodal radiation along with adjuvant radiation. So the study shows there was a marginal benefit in terms of overall survival and disease-free, distant disease-free, and breast cancer mortality all were being statistically significantly benefited from radiation treatment. So now the question whether the patient benefit with 1 to 3 nodes, we know that MA20 study was only patients for breast conservation, whereas the URTC study included both patients. So in summary, Danish data showed reasonable convincing evidence, but the criticism was the patient have suboptimal chemotherapy, and similar criticism was for Oxford meta-analysis. But when you look at the both nodal RT trials, both showed regional nodal radiation improve the local control and marginal improvement in survival, but there was significant benefit for especially high-risk patients, even with the current systemic chemotherapy. So in conclusion of my conclusion is with improved systemic treatment, still the absolute benefit of RT may be small, 3 to 4%, but the improved local control may have a higher impact on breast cancer survival. So we discuss all these cases in our multidisciplinary rounds, and we discuss the pros and cons of the patient. And usually we offer adjuvant radiation for all these patients. Now, moving to another case, this is a 50-year-old woman with invasive ductal carcinoma of breast treated with the sentinel lymph node biopsy and mastectomy. So the pathology was T2 with a micromet on sentinel lymph node biopsy, and lymph node LV was negative and grade 2. So the question comes whether this patient need adjuvant RT. So typically, radiation oncologists take micromets as N0. So typically we don't radiate. Now, this is from the Boston group. They reviewed the local regional recurrence incidence and prognostic factors for failure in N0 patients post-mastectomy. So the study shows that there is a cumulative incidence of recurrence, a local regional recurrence up to 4 to 6% at 10 years. Most of the recurrence was at the chest wall. And they found that the prognostic risk factors were close margin, T2 or large tumor, premenopausal status, LVSI. So they found that more than 30% recurrence occur when 3 or more identified risk factors. And other factors you could add into the group are triple negative or HER2 high grade and high KS67. So the recommendation, what we follow is this is the recommendation from the group was postmenopausal patient with any of the 3 factors and premenopausal patients with the 2 of the factors, they consider adjuvant radiation treatment. Now, this is another, this could be an interesting controversial question. Would you consider adjuvant RT in elderly patient above 70 with a T1 N0 ER breast cancer? Or would you definitely recommend radiation in elderly patient with a ER positive early stage breast cancer? So you all know that there is a cancer leukemia group B study and also the PRIME2. And cancer leukemia group study showed statistically significant reduction in local regional recurrence without significant benefit in overall survival. And the PRIME2 study also showed the same. The PRIME2 study was women above 65, whereas cancer leukemia group was above 70. And both studies showed a similar outcome. Now, based on the North American study, the NCCN recommended omission of RT in elderly patients with low risk early breast cancer who are prescribed endocrine therapy for 5 years. Now, omission of breast radiation could be controversial because PRIME2 study showed grade 3 tumors, LVSI positive or ER negative, were associated with a high rate of local regional recurrence. And the cancer leukemia group trial provided no information about the impact of LVSI status or tumor grade or comorbidities on patient outcome. And the endocrine therapy arm had a 10% local regional recurrence. Then multiple studies shows that endocrine adherence, elderly women, is only about 50% at 5 years. Then there are two other studies in the past. One is the NSABP B-21. They randomized women less than 1 centimeter tumor after breast conservation to TAM, RT, or RT plus TAM. And they compared the combination to endocrine alone or RT alone after breast conservation. And in this group, 16% of women were above 70 years, and there was no statistical significant difference between overall or disease-free survival among the groups. Plus, there was high incidence of breast cancer recurrence with the TAM compared to RT, and the fewer breast cancer events were with RT alone. Another randomized study from the Europe is the German breast cancer study. They randomized RT and TAM into 2x2 factorial design. And in the group, age group was 45 to 75 with low risk breast cancer. Again, the study shows there was no, the event-free survival was the primary endpoint. There was no difference. And also reported age was not a prognostic factor. We also looked our own data about 1,100 patients, and we found no difference in relapse-free survival or breast cancer survival, specific survival between RT and endocrine. And our patient group endocrine adherence was around 48% at 5 years. What we found was comorbidity in older patients was independently associated with a reduced overall survival. So what we do, this type of patient, we discussed in the MTR and the options. She can have 5 years endocrine therapy versus 5 days of radiation. Either you can give a the fast forwards protocol, 5 days of radiation, or you can do partial breast radiation. Now, there are multiple publications from North America, how much impact on the NCCN recommendation of omitting radiation, and they found that 1 to 2% only. Now, recently, Energy RTOG group and the Canadian group are formalizing a clinical trial that will be prospectively comparing radiation versus hormone in elderly patients. Now, one more case I have, this is about DCIS. How do you manage a patient 70-old with DCIS? The lesion is low risk 1 centimeter, grade 2 without necrosis and 3 millimeter margin. Patient had a lumpectomy. So the question is, do you offer adjuvant RT? I would like to review two studies. One is the RTUG 9804. This was a similar group, mammographically detected low or intermediate grade DCIS measuring less than 2.5 centimeter with a clear margin of 3 millimeter. They compared RT with observation and found that 6.7% was the recurrence in the observed group, whereas RT 0.9%. So very, very low incidence of recurrence. Now, similarly, there is an ECOG study presented prospective. They divided it was a prospective study. There were two cohorts. They divided the group into low, intermediate grade DCIS into one, up to tumor size 2.5 centimeter. Another was cohort 2, high grade DCIS up to tumor centimeter, 1 centimeter. 30% of patients have tamoxifen. And the primary endpoint was ipsilateral breast event, and the median follow-up was 12 years. And they found that overall ipsilateral breast event was about 15% for cohort 1 and 25% for cohort 2. And invasive component was 7.5% and 14% respectively. So risk of developing ipsilateral breast event and invasive breast cancer increased over 12 years. So the decision, you can see 15% loco-regional recurrence at 12 years and 50% will be invasive. Of course, there is no survival benefit, but if the recurrence is an invasive, increased breast cancer mortality. So what we do if patient wishes, definitely our standard guideline is we offer radiation, but definitely the question comes, you can observe if patient wishes after, or we'll discuss the pros and cons. And if patient wishes, we'll usually offer 5 treatment or observe. So one question is actually, I think that's the one. Now, one other question comes is actually patient have close DCIS margin after breast conservation. So if this is actually the DCIS is associated with the invasive ductal carcinoma, then we only typically ignore the DCIS margin. We only concerned about the ink margin for the invasive cancer. And if you're concerned, then review the mammogram for calcification and could repeat mammogram pre-RT if you're concerned. And typically no boost or anything given, even though it's close margin. But if triple negative, there are some physician offer a boost. Now, one other thing, also topic I want to discuss is actually quite commonly come among the radiation group is patient DCIS or invasive tumor after oncoplastic surgery. So how do you define the target volume? There is an uncertainty, but typically surgical clips at the surgical cavity are very useful, and our surgeons do this routinely. There is another one called 3D tissue marker available. That is a polymer and it absorbs over 12 months. And this is expensive. The surgical clips are comparatively cheaper. That's what we do to define the target volume. So that's it. Thank you very much.
Thank you, Dr. Kurian. There are any questions for you?
I wonder if I could ask a question. My name is Shaheenah Dawood. I'm from Dubai. Thank you for an excellent presentation. You talked about patients with PT2 tumors and the factors that could govern giving them radiation therapy. And I've seen it in the NCCN guidelines as well. It's like a little script at the bottom there. But it concerns me that everyone with a PT2 now is, basically getting radiation therapy. What about those patients, say, with a 2.4 centimeter tumor, young, say 36 years old, but with an Oncotype DX recurrence score of, say, 14? Would you still give radiation therapy to those patients?
We look, thank you very much. That's a very interesting question. And now that's only one factor is not necessary to make a decision. So we have to look other risk groups actually, whether, the grade of the tumor, the margin status, then what all. So according to the current guideline, what we follow 3 or 4 factors. And this would just PT2 is not an indication for radiation treatment.
And would you radiate all the triple neg patients? Because triple negative in itself is a high risk. irrespective of the age, say a tumor that's again, say 2.4 centimeters and they've undergone a mastectomy post neoadjuvant chemotherapy and attained a pathological complete response?
No, at the moment, again, we have, I think our group, like my senior colleague was the one reported that there is a high incidence of recurrence for triple negative patients. But having said that, what we found that multiple factors like a LVSI positive or grade 3 and just a triple negative alone is not an indication for radiation treatment.
So we've displayed some questions for you on the screen. So I request you to take them.
I think this is a.
I think this is a chemotherapy-related question for Jame. I think.
Yeah, that's right. For
I think we can go to the next one. Yeah. So I think, can we avoid regional nodal irradiation in patients who have received, we are planning for post-mastectomy radiation 1 to 3 lymph node positive, and how should we select?
Yeah, so that's what I just presented. So we typically do provide radiation for all women, irrespective of nodal status, because we have now enough evidence that to proceed with the adjuvant radiation treatment. So I know there is a tendency to, I don't know if it's in Kerala, non-availability of the facility for radiation machine or not. But typically 1 to 3 nodes patient should get radiation treatment. That's the current recommendation from our group.
So would you treat only the chest wall?
No.
Would you treat only the chest wall or the regional nodal irradiation?
All the regional nodes. That's the way the study MA20 as well as the URTC study both reported regional nodal irradiation means internal mammary, also the supraclavicular, all the regional nodes actually. But the problem, our practice changed completely in North America. I think, fortunately, Amrita is the only center, I believe, which must do routinely sentinel lymph node biopsy. But I talked to different surgeons in Kerala, but they are not very keen to set up the sentinel lymph node biopsy program. That's a pity. And if that's there, it will save a lot of time for the patient as well as also morbidity. Recover from morbidity is a very important thing post-treatment. I think you should encourage people to proceed with sentinel lymph node biopsy rather than going for axial lymph node dissection. So this is actually from Dr. Haridas. Can we avoid surgery and give radiation alone in patients? This is a very interesting question. Now, what is going on with the neoadjuvant chemo then post-radiation? We know that there is a study came from earlier, and that shows that node negative patients, you don't need a radiation. But now this NSABP plus RTOG B-21 study going on for node positive patients. And they are, at the moment, we enroll all the patients into the study. So we have to wait to see whether node positive patient need radiation or not. Whether regional node, I think that's randomized into regional node radiation plus chest wall radiation, or just radiation to the chest wall alone. So we have to wait for the, so till at the moment, we just enroll patient to the B-51 study. Could you comment on tumor bed boost, in which group it is safe to avoid sequential? Or again, at the moment, everybody is doing sequential boost, but we are waiting for the NSABP, RTOG NSABP study to decide which one is the best. We don't have an answer at the moment. So typically we do no concurrent boost, we just do sequential boosting. Do you consider site of tumor in medial or central RT decision making? Not really. We follow the criteria. If there is an indication for radiation, we radiate, and there is no connection. Would you consider RT2-IMN? As I mentioned, if you're going for regional radiation, if node positive patient, we will be treating all the regional nodes. Early stage patient receiving neoadjuvant, do you tailor RT indication and regional node depending upon pathological response? I have mentioned before, just now, at the moment, we enroll all the patients with like a pre-chemo node positive patients into the NSABP RTOG B-21 study, whereas patients with node negative patients, we typically pathological complete response, patient won't need radiation unless there are some high risk features. Can we avoid boost dose in patients getting? We didn't find any difference if you boost dose and trastuzumab. We can currently give. There is no question. There's no concern, and we never come across a situation to avoid boost for patient getting Herceptin.
Thank you.
Thank you so much, sir. Can I request Dr. Pavitran to please introduce our next speaker? Over to you, sir.
Yeah, next is by Dr. Shaheenah Dawood. She's the head of medical oncology, Dubai Medical College, UAE. She will be talking on the molecular profiling and prognostic markers in breast cancer. Over to Dr. Shaheenah, please.
Thank you for the lovely introduction and the opportunity to come and present my thoughts on precision medicine through broad molecular profiling and really focusing on breast cancer. We've had two amazing lectures looking at the advances in the management of breast cancer, both from a medical oncology perspective and really how to tweak treatment in terms of radiation therapy as well. You can see everything is a personalized approach. So my talk is really to take it more into a futuristic realm and take it beyond just a clinical aspect of what we are doing. These are my disclosures. Now, we know that in the past, patients used to be treated the same. Everyone had one form of treated. Every cancer of the same location used to be grouped together and treated the same. So same location equaled the same treatment. We know now that in 2020, even within the same tumor type, such as lung cancer, individualized treatment is important because we know that if you profile those tumors, you may get different markers and different therapeutic approaches will be assigned to those markers. We also know that there are different markers that can be actually used as agnostic markers, where it doesn't matter which solid tumor they're arising from, you will treat it exactly the same. Now, going forward, I think there are four important questions that we need to ask ourselves in terms of precision medicine and advanced cancers. And the first is, what have we actually learned from these targets? Well, we've learned that identifying one important somatic mutation can in fact make a difference. This is a very early example of a patient with metastatic melanoma, who in the past would have been treated with single agent dacarbazine, and you can see that the response rate would have been approximately 5%. But if you identify a marker such as BRAF in these patients and you treat them based on the BRAF mutation, their response rates can go up to 60 to 70%, with some patients actually having long-term good prognostic outcomes. We've also learned that targeted therapy is superior to chemotherapy in a biomarker detected cohort of patients. And you see three prime examples over here. You see patients with EGFR mutation positive lung cancers where targeted treatment is superior in terms of prognostic outcome to chemotherapy. I've already given you the example of melanoma where you have patients with BRAF mutation being treated with vemurafenib, where it is a superior outcome compared to single agent dacarbazine. And of course, in breast cancer patients, those who have a BRCA gene mutation, if they're treated with PARP inhibitors such as olaparib or talazoparib, again, a superior prognostic outcome compared to standard of choice chemotherapy by physicians. So a specific mutation and a specific target actually does improve survival of patients. We've also seen the rapid adoption of tissue agnostic markers, and it's really changed the way we think about tumors. We've seen a number of agnostic markers come up in the last couple of years. We know that patients who've got MMR deficiency or MSI high tumors, you can treat them with drugs in immunotherapeutic agents such as pembrolizumab, those who have TRK fusions, larotrectinib. Those with ROS1 or TRK fusions can be treated with entrectinib. We know that tumor mutational burden is also rapidly becoming an agnostic marker. So really the theme here is one target, one drug, all tumors. And just to give you that data, you can see here in terms of MMR deficient tumors, a beautiful waterfall plot amongst patients who were treated with pembrolizumab in those who had MMR deficient tumors, and a fantastic waterfall plot here, something that is very rare to see in patients with metastatic disease. These are patients who had TRK fusions, a wide plethora of different solid tumors treated with larotrectinib, and you can see an overall response rate of 76%. But what was even more interesting that was that 93% of responding patients and 75% of all patients actually remained on treatment or underwent surgery with curative intent. We recently saw the FDA approval of tumor mutational burden being an agnostic marker based on the Keynote 158 trial that looked at pembrolizumab amongst a plethora of different solid tumors, where the cutoff of more than or equal to 10 was used. I think the question that comes up here is in the Keynote 158, there were practically no breast cancer patients that were enrolled in that particular trial. So it really does raise the question whether it is actually feasible for TMB of 10 to be that agnostic marker that we're looking for in patients with breast cancer that we know inherently is not as immunogenic as some of the other tumors like melanoma, lung cancer, and endometrial cancer. My personal thoughts are that you need a different cutoff of TMB for different solid tumors, but that's a discussion that we could have later on. We also know that multiple target testing is increasingly becoming important because one target and one drug eventually leads to a resistance. We know that one target and one drug does not inform on more potent targets, and one target and one drug does not give you the whole biological picture of that particular patient. And I think the prime example comes from lung cancer, where you really need to know all the information, including the mutations that patient has, the PD-L1 expression, TMB level, those agnostic markers such as NTRK. And of course, you need to combine it with the phenotypic features and then choose the most appropriate therapeutic modality that you're going to actually devise for that particular patient. Multiple targets also allow you to expand the population cohorts that can benefit from therapy. And again, I feel the prime example here is really looking at those immunotherapy biomarkers. We're all in this era trying our best to give patients immunotherapy because we know that those patients that actually respond have a long, durable response. And we know that PD-L1, MSI, TMB, and interferon signatures are all biomarkers for the use of immunotherapy. And it's important to test all of them because a lot of them are actually not overlapping. You may have a patient with a high PD-L1 expression, but MSI low, and the same goes for TMB. So again, it's important to have all the information so that you can expand the cohort of patients that could benefit. And finally, profiling provides insights into treating those really rare and difficult cancers, including those cholangiocarcinomas, the adenoid cystic carcinomas, and of course, more interesting for us as breast cancer physicians, those metaplastic breast carcinomas, where we know that patients inherently do very badly, especially in the metastatic setting. So we try to look for those one or two biomarkers that could help guide therapeutic management and improve the prognostic outcome of our patients. So in the clinic, when we have patients with metastatic disease, as medical oncologists, we know that progression-free survival gets shorter with subsequent lines of therapy. And what we want to do is use that best therapy early on in the treatment of our patients. We want to be able to switch therapy early if it is not working. And hopefully with the use of molecular profiling platforms, we want to be able to answer that question, does the progressive decline continue with guided therapy? And the simple answer is it probably doesn't. But again, we have a lot of work in this realm. We know that precision oncology is a framework for patients in 2020. This is what you see, and this is what generally needs to be done. If a patient's tissue is being biopsied and sent for sequencing, the results should be discussed in a molecular tumor board. The physicians that sit in a molecular tumor board will then put together the logistics, determine the cancer heterogeneity of a patient, and also will look at the data that's come out from that next generation sequencing to be able to determine the magnitude of clinical benefit when you're thinking about using those targeted therapies. And then putting all that together will then formulate a treatment plan that is most appropriate for that particular patient. I think the next question moving forward, and specifically focusing on breast cancer, is that is there a role for profiling in patients with advanced breast cancer? Now, as a clinician, we have a very simplistic view of how we see our patients in the clinic. We know that 15% of our patients have triple negative breast cancer. We tend to give them chemotherapy. Patients have hormone receptor positive disease that constitutes 70% of our cohort. We tend to give them endocrine therapy here because we know it reduces the risk of mortality associated with breast cancer. And of course, we just heard a brilliant lecture looking at patients with HER2 positive disease where anti-HER2 therapy is the cornerstone for these patients. But I think that simplistic view has changed significantly from just looking at those three subtypes to really looking at breast cancer based on genomic drivers. And this in itself, this pie chart that you see here is also no longer that simplistic. It has gotten more complicated with time. We know, and this is a prime example, this is a study that looked at whole exome sequencing analysis of 617 patients with metastatic breast tumors. And you can see here, in terms of the somatic genetic alterations that you see in metastatic breast cancer, you see a wide repertoire of different mutations. And when you try and compare it to early stage breast cancer, it is very, very different. What you see here is a comparison of the mutational process where you see 9 driver genes, such as TP53, ESR1, GATA3, KMT2C, NCOR1, AKT1, NF1, and RP1 were more frequently mutated in ER positive, HER2 negative metastatic breast cancers. We also tended to see 18 amplicons were more frequently observed in the hormone receptor positive, HER2 negative metastatic breast cancer. And specifically, when you look at those patients with triple negative breast cancer, you tended to see more alterations in genes related to homologous recombination, DNA repair. And of course, you find a higher tumor mutational burden in patients with metastatic breast cancer versus those with early stage breast cancer, simply because you have more neoantigens in the metastatic setting. Can we use these targets to be able to help build clinical algorithms in the realm of breast cancer? Well, like I said, in a very simplistic manner, we as physicians tend to look at our patients who have triple negative, hormone receptor positive, or HER2 positive breast cancer, but this assumes only 3 biomarkers. It assumes that the biomarkers stay static, and we know that as tumors evolve, 30% of these biomarkers can actually change. And it also assumes that only one pathway is dominant, an assumption that we know now is not necessarily true. So just giving 2 examples, one is in the realm of metastatic triple negative breast cancer. This is the way I think we're going to be looking at our patients in the first line setting in the very near future, where after profiling your patients, you will be looking at defective DNA repair pathways where PARP inhibitors do form the cornerstone of therapy. We'll have those inflamed phenotypes where immunotherapy is the cornerstone of therapy. Androgen receptor positive disease, bicalutamide and enzalutamide has shown a role in treating these patients. We know that alterations in the PIK3CA pathway, there is a role for AKT inhibitors. And this year at San Antonio, we'll be seeing some very good data looking at inhibiting the PIK3CA pathway with chemotherapy. And of course, those other genomic alterations such as HER2 mutations, NTRK fusions, and RET alterations, where we know it plays an important role in patients with metastatic triple negative breast cancer. Now, just reminding you of 2 important clinical trials. We have the Impassion 130, which was a phase 3 clinical trial that randomized triple negative breast cancer patients in the first line setting to either atezolizumab plus nab-paclitaxel or nab-paclitaxel alone. And we know that in the PD-L1 positive population, there was a survival advantage of about 7 months, making it an important therapeutic modality in these patients. We've also seen the results of the Olympiad and the EMBRACA trial that looked at patients with germline positive BRCA mutations and patients who were randomized to either a PARP inhibitor or standard of care chemotherapy. And again, you can see that PARP inhibitor did trump chemotherapy. So how are we going to sequence based on these targets? And this is one potential algorithm that you can build for your patients with metastatic triple negative breast cancer in the first line setting. It's important to test for PD-L1, and if your patient is PD-L1 positive, standard of care would be atezolizumab plus nab-paclitaxel. I would remove the paclitaxel. Now, this algorithm was built prior to the results that were presented at ESMO. And then in the patients who are PD-L1 negative, you'd look for those other biomarkers such as BRCA mutation, and then look at using PARP inhibitors as well. So again, you can build that algorithm in patients with triple negative breast cancer. What about your patients with hormone receptor positive HER2 negative breast cancer? Well, some of the targets to consider here are, of course, ERPR status of a patient, which, like I told you, can actually change over time. I tend to rebiopsy patients quite a bit, depending on the duration of treatment that they've been on. We know that there's a development of ESR1 mutations in patients who have received aromatase inhibitors. We also need to look at defective DNA repair pathways, where we know that PARP inhibitors do form an important component of treatment in these patients. Again, alterations in the PIK3CA pathway. There has been data looking at using AKT inhibitors in this cohort of patients. Again, some nice data that will be coming up very soon. And of course, looking at those other genomic alterations such as HER2 mutations, NTRK fusions, and RET alterations. I think in the realm of hormone receptor positive breast cancer, it's always important to look at that biology and understand it very well. And you can see from this diagram over here that when patients have endocrine sensitive disease, they have small clones of cells that can cause endocrine resistance, but again, very, very small clones. But when you start treating these patients with hormone therapy, you're actually allowing these clones to increase. And as patients develop endocrine resistance disease, about 18% develop ESR1 mutations, 9% have defects in the MYC pathway, 13% have defects in the MAP kinase pathway, and of course, 60% have other defects as well. And it is these acquired genomic alterations that results in endocrine resistance. And the question that we ask ourselves is that could evolutionary tracks actually influence the choice of subsequent therapy? And the simple answer is yes. It can, in fact, influence the choice of subsequent therapy, as something that we will look at later on. But we also need to look at the genomic landscape of ER positive metastatic breast cancer, looking at some of those other targets that have come up. We know that somatic mutations in metastatic breast cancer differs from early stage breast cancer, and I showed you that earlier on. But what's interesting in the realm of ER positive disease, ApoBac signatures are rapidly becoming very important, where these patients actually have high TMB and could actually benefit from immune checkpoint inhibitors. We've also seen that metastatic patients, like I said, even in the realm of hormone receptor positive disease, can have higher tumor mutational burdens. I had a patient recently, not so recently, with an ER positive disease that had a high TMB of more than 10. As per FDA guidelines, you could potentially use pembrolizumab in those patients. We've seen the results of the SOLAR-1 trial that has looked at patients with endocrine-resistant metastatic hormone receptor-positive disease who have a PIK3CA mutation, where you know that the combination of alpelisib and fulvestrant actually trumps fulvestrant alone. So again, how are you going to sequence? How are you going to look at all these biomarkers and put them together? An important and emerging biomarker in the realm of hormone receptor-positive disease is also the acquiring ability of these tumors to have HER2 pathogenic mutations. And this was the results of the phase 2 SUMMIT trial that looked at the combination of neratinib plus fulvestrant amongst patients with hormone receptor positive metastatic disease who had acquired a HER2 pathogenic mutation. And when they gave a combination of neratinib and fulvestrant, they actually reported a very nice clinical benefit rate of 47% and a progression-free survival of 5.4 months. And a lot of these patients had actually been pre-treated with fulvestrant, again, another marker that one needs to consider. So a very simplistic view of how you would think about sequencing these patients with hormone receptor positive disease in the first line setting. CDK4/6 inhibitors plus an AI is standard of care. There's no question about that. But when patients progress, it's important to test for that PIK3CA mutation status. And if they have mutation positive disease, alpelisib and fulvestrant does form the backbone of treatment in these patients. And as you know, at ESMO this year, we did show, the authors did show that there was an improvement in overall survival, although not statistically significant. And of course, if they're wild type, you could give fulvestrant in the second line setting. And then post progression of the second line therapy, you could look at other markers such as BRCA, where PARP inhibitors would be important, HER2 mutations, where neratinib plus fulvestrant is something that you could think about, and of course, enrolling them into clinical trials. So what is the best profiling strategy? So this is the last question that I'm going to ask and giving you some clinical examples of looking at why looking at the whole story makes it important when you're looking at these patients. And like I said, the whole story is important, and therefore you need to order that right test, tumor profiling that assesses DNA, RNA, and proteins to reveal a more complete molecular blueprint to guide precise and individualized treatment decisions that are proven to extend overall survival. And I think this is if there's nothing else, I think this is the basic statement that I hope everyone takes back home. And the information you need when you're trying to actually profile your patient includes whole exome sequencing from your DNA, which can provide information on mutations, indels, copy number variations, MSI status, TMB, and of course, loss of heterozygosity. Whole transcriptome sequencing of RNA gives you that important information on fusions. You need also that information of protein immunohistochemistry to determine ER, PR, HER2, ALK, PD-L1 status, MMR, and of course, androgen receptor. It's important to couple it with germline testing, such as BRCA, CHECK, and PAL-B2, and I'll show you some information for that later on. And of course, the wave of the future is inclusive of artificial intelligence. Now, of course, this may not entirely apply to patients with breast cancer, but I think artificial intelligence is the wave of the future where having all this information that you derive from the DNA, RNA, and protein immunohistochemistry, as well as germline testing, can be computed together to actually give you those individualized therapeutic plans so that if you have multiple targets, what is the best target to use first? Again, it is the wave of the future and not something I'll be talking about today, but something that's very, very interesting. So just to give you a couple of examples, this is whole exome sequencing, and that essentially means that the total exons of the genome is actually being looked at. And you know that the exons constitutes about 1 to 2% of the genome that encodes the proteins. And like I told you, it provides information on point mutations, insertions, deletions, copy number alterations, MSI status, TNB, and of course that loss of heterozygosity, which is very important. We know that homologous recombination deficiency assays measures a genomic change caused by homologous recombination deficiency. And in order to be able to determine that, 3 important pieces of information that can be derived includes loss of heterozygosity, telomeric allelic imbalance, large-scale state transition. And if you have even one of this, it essentially tells you that homologous recombination deficiency actually exists in that tumor type. So just to give you an example, this is a patient who is a 40-year-old. She presented with a breast mass. It was ER/PR positive, HER2 negative. And she, on PET-CT scan, unfortunately was found to have a solitary liver metastatic disease. We biopsied that. It was in fact disease, and we sent it off for profiling. Now, she was immediately started on a CDK4/6 inhibitor plus endocrine therapy with an aromatase inhibitor. And of course, we incorporated ovarian function suppression, but her profiling report was very interesting. She had a PIK3CA mutation up front, suggesting that if she progresses, we could potentially give her a combination of alpelisib and fulvestrant. She did not have either a somatic or a germline BRCA mutation, but she did have a high loss of heterozygosity that was detected in her tumor, and there is upcoming data looking at expanding PARP inhibitors beyond germline BRCA, and loss of heterozygosity, especially high loss of heterozygosity is one of those biomarkers where you could potentially look at using PARP inhibitors. But more importantly, this patient actually has a pathogenic HER2 mutation. And so at some point, I will be probably using a combination of fulvestrant and neratinib as per the Summit trial, really giving her that opportunity for several lines of therapy, looking at this profiling report. This is another example of a 36-year-old lady. She presented with stage 4 de novo breast cancer. It was a triple negative breast cancer. She had a germline BRCA1 mutation. It was PD-L1 positive, and you can see that from the profiling report here. And we gave her atezo plus Abraxane. She responded beautifully to treatment, but of course, eventually progressed. I put her on a PARP inhibitor, and she had a progression-free survival of about 6 months before she progressed. And at that point, I decided to biopsy her lung met and set it off for profiling again. And interestingly, I got back the fact that she has a BRCA reversion mutation, suggesting that when I used PARP inhibitor for her, it actually, the BRCA1 gene that she had in terms of her mutation had actually regained its function. It will be interesting to see now that I've put her on third line chemotherapy, what would happen to this BRCA reversion mutation, because there's some evidence to suggest that when you take away the PARP inhibitor or you take away the platinum, these BRCA mutations can be reacquired again. But again, that would be very interesting to see, because I would like to re-challenge her later on when she progresses with a platinum-based therapeutic agent. This is another example, a 60-year-old lady, stage 4 de novo breast cancer, ER/PR positive, HER2 negative. She was treated with palbociclib plus an aromatase inhibitor. Unfortunately, after a year and a half, she had progression of disease in her liver. I biopsied it, same biology of disease, and I sent it off for profiling. She does not have a germline BRCA mutation. And as you can see, she has an ESR1 mutation, again, something that we thought that she would definitely have because she had received aromatase inhibitor in the metastatic setting for about a year and a half. Interestingly, she actually has a somatic BRCA2 mutation. And remember, I said she does not have a germline BRCA2 mutation. And we know from ASCO this year, from the TBCRC 048 trial, where PARP inhibitors were explored in patients with metastatic breast cancers with germline or somatic mutations in the HR pathway beyond germline BRCA1, BRCA2. And what you can see here is that those patients who had a somatic BRCA1, BRCA2, yes, only 17 patients, because we know that somatic BRCA1, BRCA2 is actually quite rare in the absence of a germline mutation. But 17 patients were treated with a PARP inhibitor, and there was a 50% response rate, overall response rate in this cohort. And I certainly think that, yes, we need to wait for more longer follow-up data, perhaps bigger clinical trials, but in a patient with metastatic breast cancer, and if once they've progressed on second or third line therapy with endocrine therapy, I'd be more than happy to use a PARP inhibitor in this particular patient. And then, of course, like I mentioned, RNA sequencing is extremely important. We know that gene fusions that are detected in the DNA using next generation sequencing requires tiling of intronic regions known to likely harbor that genomic breakpoint. But this approach is challenging because we know that introns are just too long to tile, and the introns contain repetitive elements that are unmappable. We also know that genomic breakpoints take place in alternative introns not predicted by the panel design. So RNA sequencing offers a more direct approach to fusion detection as the introns are removed by splicing. And just want to give you a practical example. This was a data set, it's actually lung cancer, but I think it also informs on all types of solid tumors, really looking at the importance of RNA sequencing to look at those fusions. This was a cohort of patients with lung cancer that were profiled using MSK Impact from Memorial Sloan Kettering, and about 232 of these patients had fusion negative disease. And as you know, the MSK Impact platform only looks at DNA sequencing, doesn't incorporate RNA sequencing there. So what they did was they went back and they reprofiled these patients with RNA sequencing, and they found that 36 of these patients actually had fusion positive disease, of which 10 actually benefited clinically from targeted therapy. So again, showing that it's important to really find those fusions. And in fact, the NCCN guidelines actually incorporated that you need to consider RNA-based NGS, if not already performed, to maximize the detection of fusion events. Now, why is that? Well, this was a very nice study that came out of Cancer last year, looking at patients who had fusions and how they were treated. If you look at the cohort over here, if you matched patients who had fusions to appropriate targets, you know that they will inherently do better than if you don't have matched therapy. But they also looked at cohort of patients who had fusions plus other targets. And if they had other targets and they were matched for that therapy first before their fusions, you can see that they're not doing as well. You can see that patients matched to fusions, the median overall survival was about 11.6 months. If they're matched to other alterations, about 4 months. And if they're unmatched, of course, it is about 5 months. So again, it's important to use those fusions first. And so this was a case of a 30-year-old lady that I had with breast cancer, stage 4 de novo, ER/PR positive, HER2 negative. She presented with extensive bone and liver metastases. She was diagnosed elsewhere, and then she came to see me. And at that point, I commenced her on abemaciclib plus an aromatase inhibitor plus ovarian function suppression. But I also immediately sent her tissue for profiling. Now, what you can see here is that the profiling report actually was very, very interesting. She had ER positive disease. We know that she had a PIK3A, or she does have a PIK3CA mutation, so making her a candidate for alpelisib and fulvestrant. Very interestingly, she had an NTRK fusion as well, an NTRK3 fusion. She also had a tumor mutational burden of 9 and an androgen receptor protein expression of 95%. So she had a progression-free survival of on abema and an AI of almost 6 months with only a partial response before she started progressing. So at this point, the question was what to do next. So we considered giving her first alpelisib plus fulvestrant, but my personal feeling was that it was important to target that fusion because I thought that that was the more important target at that time. I had a long discussion with the patient. I was very clear to her that breast cancer patients enrolled in those entrectinib and larotrectinib trials were very small cohorts. The better data was coming from the SOLAR-1 trial, but she elected to try entrectinib, which we had on a special access program. And interestingly, she's now got a progression-free survival of 8 months. She's, well, it's not really 8 months because there is ongoing response in her. Her last PET CT scan, as well as MRI of the liver, shows a complete response. The tumor has completely disappeared from her breast, and her bones no longer show any FDG avidity. So she's actually had a very nice response, and it has been going on for more than 8 months. So in my last 2 slides, I think we've really moved past the whole era of, you know, that how universal tumor sequencing was not something that we could advocate for. But I think in 2020, all cancer patients should have access to genomic testing. It's based on the discussion between the patient and the physician, as well as what is accessible to that patient, that one needs to think about profiling their patients at that particular point in time. My last slide is what do I do in my clinical practice? In the ideal world, I would like to send off every tissue sample of every patient in the metastatic setting for profiling. We obviously can't do that. We do need to pick and choose. So those newly diagnosed patients with metastatic disease, if they have non-small cell lung cancer or triple negative breast cancer, rare tumors, colorectal cancers, pancreatic or unknown primaries, these are the patients that get actually sent for tumor profiling up front. If we do not profile those patients up front, or they have other tumors, we then at progression of disease rediscuss their cases in our multidisciplinary tumor board to see if there would be a clinical utility or benefit to profiling those patients at that point in time. And if there is, we tend to try and get that fresh tissue sample for profiling. And so that is it for me. And thank you very much for inviting me to share my thoughts on profiling in the realm of breast cancer. Thank you very much.
Thank you, Dr. Shaheenah Dawood. That was a wonderful coverage of the molecular profiling in breast cancer and the tumor biomarkers. And you seem to have generated a lot of interest in the topic, because we've have a few questions in the chat box. Shall I go to the questions, ma'am?
Yeah, sure. Please go ahead.
Yeah. So the first question was from Dr. Haridas. He asks, what is the therapeutic implication of MSI status in breast cancer at the moment?
Well, as we know, MSI is an agnostic marker, and if you do find it, it does give the opportunity for patients to be treated with single agent pembrolizumab. So if it's there, I will treat my patient with it, and I've seen it. No, I personally have not picked up an MSI in my breast cancer patients. It's very rare to do so, but I have had colleagues who have picked it up. And the response rates are tremendous.
Okay, thank you, ma'am. So the next question was, how frequently do you repeat sequencing in metastatic breast cancer? Do you send the tumor for sequencing every time the patient has a relapse?
No, I
Yeah.
I would have to have a lot of money to be able to do that.
Correct.
Because sequencing is very expensive. It really depends on the clinical situation and what the tumor board actually recommends. If I had the ability to do so in patients with hormone receptor positive and triple neg, all of them in the first line setting, I will send it for profiling. And as you can see in the patient that I did send for profiling, I was able to pick up an NTRK fusion. Yes, very rare, but you need that one patient where you could potentially cure. Then I see what happens to these patients if they've stayed on therapy very short term, especially triple neg. If they've had like a PFS of 3 to 4 months, I will not send it off for profiling again. But if they've been on therapy for a long period of time, I will, and then they progress, I will then rebiopsy and consider sending it for profiling, because at that point I know that they may have acquired a mutation that might help in terms of their therapeutic management.
Thank you, ma'am. I hope that answers the question. And the next question is from Dr. Arun Warrier. He asks, other than the Myriad panel, are we justified in using other labs for sending for HRD testing? Because all the trials are based on the standard Myriad lab results. So it wouldn't be possible for, yeah.
So the myriad testing is you've got to distinguish between germline BRCA and HRD. Yeah. And that, so you can test for BRCA with whatever platform you want. With HRD, the approval that's come is for actually ovarian cancer, in which you want to be able to look at those 3 things that I stated in my slide, which is what the definition is for patients that have high HRD, in which they would be a candidate for a PARP inhibitor. But what Caries does is that they do whole exome sequencing that can actually give you the entire platform for actually looking at that loss of heterozygosity. And if I have a patient that has a high has a loss of heterozygosity that's that high, I would attempt to use a PARP inhibitor in that particular patient if I don't have the information derived from Myriad for ovarian cancer, because that's specifically for ovarian cancer.
And the next question is regarding a tumor heterogeneity. Which would be the best method to avoid tumor heterogeneity, especially in the recent approvals for circulating tumor? We have liquid biopsies. So the question is, which would be the best method to avoid tumor heterogeneity, especially in metastatic breast cancer?
So you can't actually avoid tumor heterogeneity. You want to be able to look at the entire tumor as one platform. And so when you biopsy tumors, you may miss one area that may have different biomarkers versus other areas. I don't think it's so much of a problem in breast cancer as it is with other tumors, but you're right. Liquid biopsies do give you the more comprehensive biological makeup for your tumor. The only caveat there is that if your patient doesn't have a high tumor burden, you may actually do the cell-free DNA or circulating tumor DNA, and you may not get any biomarkers back simply because you haven't had that entire it hasn't been shed into the
blood. Yeah.
So I still think the gold standard is biopsy first line. You actually have to biopsy your tumors first line so that you can make that diagnosis, and that tissue needs to be sent off. And then when that result comes back, it needs to be, and I showed you that framework for 2020 where the information has to be looked at in a molecular tumor board, and that tumor board will see whether we may have missed something based on what we're seeing clinically, based on what we are seeing radiologically. Did we miss it because of tumor heterogeneity? And at that point, if a patient requires a liquid biopsy, we'll certainly do it. But like I said, there are many caveats to doing liquid biopsies.
And also, ma'am, if you have a patient who has progressed, say, in the liver and also progressed in the breast or the regional lymph nodes, which would be your site of biopsy that you would choose to send for profiling?
So ideally, I would do the liver.
Yeah.
However, you also have to see what is the most accessible site. So you have to work with your interventional radiologist to see, is it going to cause harm? Because if it's going to cause harm, I will not do it. Sometimes you have just these little tiny dots on the scan, and the interventional radiologist will say, look, we're not going to be able to biopsy this adequately, or if we do, it's in a position where it might cause bleeding. So there are a lot of things that you need to look at, but if I could, it would always be the liver.
And also there's one last question on the use of immunotherapy beyond second line, because in the wake of recent ABC guidelines, it's not very clear whether, it's really going to benefit beyond the second line in breast cancer immunotherapy. This question is from Dr. Arun Warrier.
So the data that we have is first line. The data that we have is not second line. So that's why I said it's important to test PD-L1 status in the first line setting. And if it is positive, you use atezolizumab and nab-paclitaxel. But the point is that we don't live in an ideal world. If your patient has received something else and has progressed, you still have phase 2 data that has actually shown that there is some benefit to using immunotherapy, but the benefit decreases. So it's not like it's not there. The benefit decreases significantly in the second and third line. So if you're going to use an expensive drug, you want to maximize on that benefit. That benefit, the maximum benefit you're going to get is in the first line setting. Not to say that there won't be benefit in the second and third line if your patient is PD-L1 positive.
So I think that's all the questions that we have. If anybody else has a question, you're free to ask. Okay, so thank you so much, ma'am. I think that was an excellent lecture on the molecular profiling, and you gave us a wonderful view into the future, for us clinicians as to what holds in breast cancer therapy. So I think I'll hand the discussion back to Dr. Pavitran. So I think we'll have the general body. Pavitran, sir.
Yeah. Dr. Arun Warrier.
Yeah. Hello. Good evening to all. So I think we had a very good CME today. So as I had put in the group, we had the charisma from the Cleveland Clinic ahead today, and the intellect from Alberta, and he was very crisp about the slides, and we had a lot of learning points from the Kurian sir. And also we had the flamboyance from Dubai, and more than, it was a very futuristic talk also, and I think all of us, we all have to do a lot of things for our patients, and if possible we should try to do that. So these are things which we learned today. And thanks to the meeting was supported by Lalpath Lab and the Caris Life Sciences, and they also gave us a platform to Kavina Creations, and Kashish Parik did a splendid job, and that may be the reason why our attendees touched almost 100. And more than Cochin Oncology Group, I think many other people also benefited from today's interactions because of the support. So thanks to all for attending. And I think the main thing about general body is that we should have one every year in the year. So we are now completing 5 years. 2015 was the first time we had a meeting, and 2016 was the first official. And we were lucky to have Dr. Jame and Dr. Kurian previously also with us. And we had a lot of CMEs. And now currently the main thing was Dr. Warren has now accepted. I think Warren is here among the participants. I'm not sure whether he is there or not. Warren is there. So he has agreed. Warren. So welcome to the governing body of Cochin Oncology Group as a new treasurer instead of Nikhil, who has gone abroad. So that is one change. And routine, our the scientific committee, all these things are there. So I hope we do continue the CMEs. And I think Sanju could not join today. So Sanju was one who was taking care of the scientific activities and planning.
Sorry, Arun, so you'll have to unmute your mic again.
Yeah. So I think so we can have in the future discussions about how to do in the post-corona, how we can all start the routine interaction, which I think we are all waiting eagerly for. Anything else from the others here? Right. So I think we can close for the day. Or there's anything else from your side?
Nothing. I think, yeah.
Okay.
It was a very useful and fruitful meeting because, as you said, it touched almost 100 participants.